Before we get into, you touched about cardio-oncology, which I think is super important that we're going to talk about that. It's a really sort of an area that we've given short shrift to, and there's a lot of really interesting data on that these days. But let me get back to you, William, in terms of, and I think this is important, just the sort of the basic blocking and tackling. You're going to start a therapy that is T suppressive, whether it's an agonist or antagonist, and how you get there more rapidly with one versus another. We'll talk about the AE profiles. But tell me, what in your practice, how are you monitoring testosterone levels? Do you get a baseline testosterone level? When do you check a testosterone level again?
Yeah, I do get a baseline because it's very helpful for me to understand what's going to happen if we're going to stop or change therapy down the road. And I do monitor it on a fairly regular basis, at least 4 times a year. Now, you may argue that you don't need to check it that often. Certainly in the beginning, for example, they're rare, but there are ADT failures, patients who get an androgen deprivation therapy and actually don't have an appropriate testosterone suppression. And it gives us information that I think can be helpful to monitor what's really happening to their disease. It's because the PSA is always going to be in relation to their testosterone levels. And in fact, we know prognostically that's also important about why some therapies, for example, AR-targeted therapies may work better than chemotherapy, for example, in certain circumstances.
So does anybody not check a baseline testosterone level?
Always.
Okay, so if you check a baseline testosterone level, patient's eugonadal, Nancy, where are you aiming? Where do you want that T suppression to be?
Well, everybody says you want it to be castrate, which is defined as less than 50. But most of us, at least myself, I would like to see it less than 10 or less than 5. The lower the better, as far as I'm concerned.
Mm-hmm. Pedro, same thing? Or
yeah, no, I agree. I usually quote, for sure, the definition is 50. I use below 20 because that's kind of what we expect with surgical castration. And more contemporary data kind of suggests that the lower the better when you have the analysis by quartiles, if you will. But I would like to highlight with Dr. Williams' point that indeed, if we do prostate cancer enough, we're going to get 1 or 2, 3 patients a year where despite LHRH, for instance, he's not well suppressed. Mm-hmm. And so we see a number of CPSA rise, we don't know what's going on, and it's just a consequence of the fact that we don't have therapeutic levels of testosterone. In those circumstances, we can either switch to a different LHRH. In some cases, we can revisit the concept of surgical castration, but it just, and actually this happened to me in the last month, and so, I had a call specifically about that. So it's something which we should talk. We do expect efficacy in above 90% of the times, but I think the literature refers to 4 to 10% where the therapeutic levels of testosterone are not achieved.
Right. So you'll switch, right, because maybe there's a mutational event in the anterior pituitary, maybe it's metastatic tumor making extra T, maybe it's an adrenal source. Right. So you'll switch an agonist to an agonist, or will you go agonist-antagonist or antagonist-agonist, or bilateral orchiectomy, or all combinations?
That's a great question. I don't know. I don't think we have level 1 data to answer that question definitively. I usually pick another agonist just because it's more convenient. The antagonist so far is every month. I often do it every 4 to every 6 months in clinic. Yeah. I do have that discussion. As Alicia mentioned, if I have a patient with cardiovascular events in the first place, I'm gonna have a low threshold to offer him an antagonist. We're gonna have that trial is gonna answer soon that question about cardiovascular safety, comparing agonist with an antagonist. But yes, it's kind of a dealer's choice. Some patients are not open, or most patients, I would argue, are not open to to get surgical castration. So I would argue that our discussion is oftentimes about agonist versus antagonist and how often are we going to do the shot.